Hi, my question's for Dr. Demuzio. Why is it that calcification eventually causes the ABI to go above 1.4?
That's a really great question, and it brings up the concept of non-compressible vessels. What can happen in certain populations, such as diabetics, patients with renal failure, and patients who are older, octogenarians, nonagenarians, is that their blood vessels become real stiff. And whether that blood vessel is occluded, meaning, well, stenosed essentially, or wide open, when you perform the ABI, you can't crank up the blood pressure high enough where it takes a falsely elevated amount of blood pressure for the flow to cease. A normal ABI is from 0.95, almost 1, up to about 1.3. In performing the ABI, if you find that the measurement is above 1.3, that suggests that there's stiffening of the arteries. And then you can't report it as something being normal. So if the blood pressure turns out to yield an ABI of, say, 1.7, the ABI basically doesn't say that, oh, they've got great blood flow. It means that they have diseased blood vessels. They may not be occluded, but they're definitely diseased. And I would report that out as being an abnormal study, someone that would merit further investigation. And that further investigation is done in a vascular lab where they no longer look at segmental pressures, but then they look at segmental waveforms, which are not altered by vessel calcification, and then also toe pressures. So that will be seen in this population, but if you are getting non-compressible vessels, you report that as something that should be further investigated. Great question.
Okay. I have a quick follow-up. So would initially the ABI would come down because of mild stenosis, right? And then eventually it would come back up because of severe stenosis and becoming uncompressible. Is there a point where that crosses back through normal and you actually have a falsely normal ABI?
Again, non-compressibility doesn't necessarily mean there is stenosis. As soon as they're non-compressible, we have to look at the waveforms to determine if there is obstruction. But yeah, there's certain degrees. There may be calcified arteries that are partially non-compressible, and that's where you're going to get the 1.4, 1.5 rating. And then there's going to be vessels that are completely calcified, and you have an infinite ABI, meaning you can't crank it. You'll cause patient to have discomfort as soon as you crank it up above, say, 240, 250, and you still hear the Doppler. Just stop, and that's a non-compressible vessel, and that's how you report it out.
So I have a question. In screening these populations, if we, say, for example, get a low ABI score, what sort of general recommendations can we give to these patients prior to maybe more invasive type interventions?
Well, what we have done in the past, if it's below 9, we tell them it's a little bit abnormal, and we would tell them that we write it down for them. We have a little form, and we said, you need to take this to your primary care doctor and talk to him about a circulation test. And hopefully that'll follow up. We usually get their phone contact information, try to follow up in a week or so, make sure they went to their primary care and talk to him about, because a lot of it's insurance related and things like that. So they have to talk to their primary care about maybe getting a referral or doing, or talking about getting a circulation test. But we just make them aware that, their circulation may be not ideal, and they should talk to their primary care about, getting a full circulation workup.